welcome to Macloid's Medlive Scientific Session Summary. Today we are at Day 2 CSICON 2019 being conducted at the Ashok Hotel, New Delhi. I am Dr. Rahul Kotwal from medical team of Macloid's Pharmaceuticals. Today we have Dr. A. Srinivas Kumar with us, who is Chairman CSINIC and Director of Cardiology at Apollo Hospitals, Hyderabad. He has delivered a session on FFR utility and pitfalls. So sir, first and foremost I welcome you to the channel and I request you to summarize your session for the benefit of the fraternity.
Yeah, we had very interesting discussions in yesterday's session in NIC on Hall B. Basically it was about fractional flow reserve. It's important for us to understand what does it mean and what is important. If you find any lesion in the coronary arteries, we always should do intervention only if it is required. That means angiographically you find a lesion severity of more than 70% diameter loss and 90% areas, or you feel that hemodynamically it is important in a chronic stable patient, or if it is acute coronary syndrome patient, then depending upon the type of lesions which you find, all of us were treating by anatomically seeing on the angiogram. But sometimes when the lesions are borderline varying between 50 to 70%, there is always a dilemma whether to address that patient with intervention or not. So in FFR, this is basically assessment of hemodynamic importance of the lesion is another important modality which has come as a boon to interventional cardiology to render proper therapy to patients. So if you find a borderline lesion or varying in between 50 to 70%, how to decide whether stenting is required to that patient or not? It's very important to do the right treatment to the right patient, and then that's how avoid doing unnecessary stenting, at the same time do the stenting which if is required. So we had lot of information on fractional flow reserve in the various trials which were done before, but differ FAME1, FAME2 and of latest other trials comparing with IFRs were also discussed. So now FFR has established itself as a very important modality in assessment of lesion significance. For everybody to know what is FFR, it is fractional flow reserve. It is basically a ratio of pressures between the distal pressure after the lesion versus the proximal pressure. It could be aortic pressure. So that's how we derive this ratio. Anything which is less than 0.75 is definitely important, and if it's less than 0.8 also we tend to treat. And any lesion with this value of more than 0.8 is not hemodynamically important, and these patients can be kept on follow with medical treatment. That's what was discussed. And what is also highlighted are some of the areas of FFR which are very important, how to and get it right. The proximal LED lesion, which has a long area of perfusion and a large area of viability with less of collaterals, and it's a non-infarcted vessel, and these sort of things tend to come positive even if angiographically it looks little on the lesser side. On the other hand, if you have a very distal lesion, branch vessel disease and very little area of myocardium, or area is already damaged by infarcted segment, then you tend to get higher values of FFR which are less important for treatment with stents. That's how we get to know what is the importance of each lesion and also how it behaves on follow. That's the importance of FFR. And some of the fallacies and pitfalls of FFR, how to do it right, were also discussed. Only important thing is you need to align the guide catheters well and avoid damping, and then probably use the right type of equipment while recording FFR. If you don't record it right, then probably you could get it wrong. We have also showed some case examples where the vessels were tortuous and how to tackle, how to get this. And in the end, we also showed our TCT live case where we did how FFR helped in assessment of left main intervention. After left main to LAD crossover, LCX lesion were assessed and FFR came negative, and we left it and patient is doing fine. Other newer modality of QFR, which can be derived non-invasively without wire, had led to a lot of discussion in the end, and it is a modality of choice probably could in future which could be driving us to see which lesions to be tackled by intervention. Thank you.
Thank you sir for beautiful summary. We hope the insights will be very much helpful for the audience over there. We also look forward for any questions in the comment section below. Thank you for being part of the channel, sir. Thank you.